Now, everyone, Jo has some very, very cool news. She finished her PhD recently, and she's going to be able to share with us tonight the results from that, because those results are related to incontinence, sexuality, and especially the role pelvic floor plays in that. So, Jo, I'd love you to just take it away. Tell us about this PhD research, what you did and what you found.
All right, I'll try and speed dial it because it was actually, to be honest, quite a long process. It was about 6 years altogether, and I started off wanting to do pelvic floor muscle assessment on men that didn't involve the per rectal or the invasive approaches, because I wanted to try and always do things that would make men feel more comfortable. So I developed a couple of tests on pelvic floor muscle function in men using ultrasound, and I developed just 2 simple tests that enable men to see and measure what their function's like. So that was step 1. Step 2 was to then develop a training program that might more quickly get men to full continence and hopefully erectile function recovery earlier than what I was seeing. And historically, from starting in 2005, there has been so much growth and development in that time. And I was pleased that the results I was able to achieve were fairly much reflective of the progress that I was seeing in the clinic. So a lot of the training I did was fairly intuitive, trying to listen to what men's symptoms were and then trying to adapt programs. So essentially, my pelvic floor training ended up being a lot more aggressive or high intensity compared to the usual care that was previously recommended. So my whole PhD has been focused on how to speed up the recovery and the quality of life aspects of men undergoing radical prostatectomy. And I was really pleased with some of the results I was able to gain.
Jo, that is so exciting. Now, that sounds quite interesting, saying you did a more of an aggressive approach to pelvic floor, but it sounds like you found your results show that there was, did you say, a speed up in erection recovery? Could you talk to me about what this program is and what you mean by a speed up as well?
Okay, so basically when I first started working way back in 2005, men would be having radical prostatectomies, and at the time there was a combination of them being done open or through the laparoscopic technique, but without the robot. So traditionally, men were only referred for physiotherapy following their radical prostatectomies. And then we had a few country patients that did like a one-stop shop where they came to see me and the urologist all on one day prior to their surgery. So they started their pelvic floor muscle training preoperatively, and they more quickly progressed following the surgery with their continence recovery. At that stage, we weren't even talking about sexual function. We were only focusing on continence. So originally, we used to find it would take 6 to 12 months for men to gain their continence. And with this preoperative program, we were able to reduce that to 6 to 12 weeks. And this sort of evolved over, 5 or 6 years. And then I came across a physiotherapist from Brisbane by the name of Peter Dornan, who'd been through this radical prostatectomy process himself and had been incontinent for 7 years. And he, in fact, had then devised a program for himself, which he actually titled A More Aggressive Approach to Continence Recovery. And that involved doing pelvic floor exercises in what he called functional positions. So things like walking, sit-ups, running through rough terrain on beaches and things like that. And what he found was that his continence then rapidly improved. Historically, we've only ever encouraged men to do a usual care program of doing 3 sets of pelvic floor in either sitting, standing or lying to a maximum of 30 exercises a day. What I did was I sort of lent on Peter's work a little bit and then what I was learning in the clinic, and I ran.
Ooh. Sorry, Jo, you're cracking up a little bit there.
A total of 6 sets a day, 20 exercises that were leaving in their standing postures.
Sorry, Jo, we've had a small amount of turbulence. I think cut off just as you were saying that you were following in what you were seeing in your clinic and from Peter's approach. Were you saying that the usual care being more doing it sort of stationary, and you found that actually men doing pelvic floor when they were sort of actually in movement had a better effect?
Yeah, absolutely. So most men very quickly gain their continence when they're lying down or sitting still. But when they go from sitting to standing, or whenever they increase the intra-abdominal pressure by bending, coughing, sneezing, breaking wind, laughing, burping, all sorts of things, they tend to then leak. So what I wanted to do was try and capture that time to increase the loading on the pelvic floor by encouraging men to do all of their training in standing. And what was also important was involving something called the fast twitch fibers. And the fast twitch fibers are when you need to basically respond very quickly if you cough or sneeze, with a rapid descent upon the pelvic floor. So what I wanted to do was train men to do these fast twitch contractions that make up 30% of the pelvic floor as rapidly as possible. That was never, or is still not, part of usual care practice. So fast twitch muscles are involved in orgasm function and climacturia as well. So it also led me to, looking at how we could improve those outcomes. So I investigated that in my research as well.
Okay, this might be a good moment too, because you've dropped the word climacturia, which was one topic I really wanted to cover here, because I've had email conversations and clients who've been suffering with climacturia for a while and are still unsure exactly what to do. Could you explain, Jo, what is climacturia?
So climacturia is the involuntary loss of urine during supposedly orgasm. So it's supposed to be at that moment of orgasm when, everything's going to heighten in its responses and it's pleasurable, except there's a loss of urine. And so for a lot of men, this is quite distressing. They have already dealt with the loss of ejaculate fluid from the prostate and seminal vesicles being removed. So that's physically quite a change. But for them to then actually lose urine has been something that many men have said is quite distressing, not only for them, but for their partners. However, along the way, I actually discovered that climacturia was only one component of the orgasm dysfunction that men were concerned about. Some men don't orgasm at all. Some have pain after orgasm. And then there was a whole bunch of men that were advising me that they were getting leakage whenever there was any arousal, so even lead up to the climax. And this was men saying things like, I go to put my arm around my wife and I instantly get a leak and it really annoys me. And that was something that I couldn't find in the literature anywhere, but I was seeing it in patient after patient after patient. So arousal leakage and climacturia are pretty much associated with the nerve recovery, but also how much of the bladder neck is removed. And that pretty much determines whether or not there's sufficient smooth muscle to hold in that urine, which previously was sort of aborted by the prostate and the urethral sphincter mechanism. That was the bladder neck, that was the internal mechanism that was doing everything automatically. So nerves, pelvic floor muscles, and the amount of smooth tissue left behind all contribute as to whether or not a man will, first of all, get climacturia, or second of all, have it recover, with the range being between 20 and 93% of men experiencing climacturia. So like you said earlier, every man's experience is different.
Yes, and we've already had Fiona's mention that they think her and her partner have experienced that small amount of urine. And I wonder if everybody in the chat box, if you've experienced anything like this, to share your experience too. Because as Jo says, it's actually very wide, the different experiences people have with urination that can occur during a sexual experience, even just arousal. Jo, I hadn't realized actually that it just sounds like all the factors are involved. I think in my mind, I was wondering how much of a role the pelvic floor was playing in this, because as far as I understand it, pelvic floor exercises are still sort of the number one recommendation if someone has climacturia. For what you've discovered, and it sounds like it's more of an integrated approach, what would you suggest for somebody who's experiencing this?
Well, it's a really good question, actually, because pelvic floor muscle training does actually help about 43% of the time in patients who've got climacturia, but then there's 57% that don't improve. So what we know is there's a whole different range of things that we can try to help this climacturia reduce. So the first one is time. So Professor John Mulhall from New York, he basically talks about the second year of post-operative recovery being the time where most men will recover climacturia. And that's exactly what happened in my own analysis of my own patients. So there has to be a nerve element there. So pelvic floor muscle training is definitely the easiest go-to, but it's not going to fix everyone. Then there's other management strategies such as emptying the bladder prior to any sexual activity, or using a condom if there's a lot of leakage, and being very wary of having caffeinated drinks and alcohol later in the day or pre-sexual activity. There's medications that might be able to help. And then there's something called the Eurostop, or variable tension loop, which can be applied to the base of the penis to compress the urethra. And they're available for about $20 and really do help in at least 50% of the cases, according to the research that's been done. We do actually know as well that surgery as a last resort will fix this problem as well. So that's in a man who's not having any daytime leakage would probably benefit from just the advanced sling procedure, which is a little bit of mesh. But for guys who are bothered by a combination of climacturia and daytime leakage, they might need something more like the artificial sphincter. But there's variations within all of that as well.
Of course, thank you so much for listing how many options there are, though. And of course, the first one being the passing of time. That's so interesting that you mentioned with the second year, the literature and your own experience as well. You see improvement. You said that's to do with the nerves. Now, when you say the nerves, do you mean the cavernous nerves or the erection nerves that are surrounding the prostate?
Yeah. So something that's only come to my notice recently with research backing it, the evidence is there now. So we sometimes get patients who recover quite quickly with their erectile function and also their continence function, and they often go hand in hand. But then you'll get some patients who have a fabulous looking pelvic floor and everything seems to be perfect, except it just takes forever for their continence to recover. And basically there has been some research that shows that the cavernosal nerve, and in particular the pudendal nerve that is all surrounding that area, is actually involved in the continence mechanism. So they've done a study where they looked at men who were impotent prior to radical prostatectomy, and they got half the guys to have a nerve sparing procedure and the other half not to. And what they found was about 30% of the men who had the nerve sparing procedure got much better continence outcomes much faster than the group who didn't have the nerve sparing. Those men were not interested in their sexual function. We've always related the nerve sparing to the sexual function, but in actual fact, it has quite a role in continence function.
Wow, that's fascinating.
So really, really interesting. The main thing I think we also need to recognise is that during arousal and sexual activity, this is a feeling, a nerve thing that comes from brain and stimulation. The pelvic floor muscle, the exterior valve, is what we're focusing on. We can train that. We can make that stronger. But if there's not enough smooth muscle tissue, when it comes to that moment of orgasm, then if there's not enough tissue to close that automatically, unfortunately, the urethral sphincter or the pelvic floor sphincter actually opens in response to the nerve activity overriding the whole sexual function. So we don't have that physical block. So in terms of anatomy, if we could see if men have this membranous urethral length that's more than about 1.2 centimetres before they have their surgery, we can measure that on MRI, then things like climacturia we might be able to screen for in the future.
That's fascinating. So, and this is something that could be done now. You mentioned so an MRI can actually see this now, and that can then change the choices that are made during surgery.
Absolutely. And that also relates to continence as well. So if a man has, really good pelvic floor function, but he's been working away at it for 6 months and made no difference, he really needs to be referred for urodynamics to have a look and see what this bladder neck's doing and how long it might be before the surgery. Something that you can even measure retrospectively by just getting the radiologist to review that scan. I've done that in a couple of cases. Those guys are the ones that tend to need the corrective surgery. And rather than wait 1 or 2 years, we know earlier on now that if it's not improving, then it probably isn't ever going to, no matter how hard we try with pelvic floor training.
I often wonder that the incontinence journey that men go through, is your suggestion, look, if by 6 months you're doing rigorous pelvic floor activity and there's not an improvement, the best thing is to get that referral to see actually what's happening internally. Not just sort of adapting the exercises or trying more exercises.
Yeah. So I don't mind if a guy's improving, even if it's very gradual, and we can measure that in graphs and bladder charts and things like that. And most men are quite comfortable if they can see improvement. They do start to get disillusioned, though, if they're just stuck at the same level. And I use penile clamps and various things to try and help improve that gradually over time. 6 months is probably still considered a little bit too early to panic, but it depends on what the man's going through. If he's very, very psychologically distressed, then it's okay to start looking at things earlier. But if there's improvement, I'll often go for 2 years with someone who's very happy to work it out, doesn't want surgery, and is showing that improvement. And 2 years is about the time where we look at things for nerves to recover mostly, or the opportunity to use penile implants if the sexual function isn't at a satisfactory level. So yeah, 1 year is probably where most urologists are comfortable with, but it depends on the person's situation.
Absolutely. I've had a question coming from the chat box. Someone's asking that they've heard the diameter of the urethra can also influence incontinence. What's your experience, say, for that, Jo?
I'm going to say that I have no idea the correct answer to that one. I guess I just don't spend any time measuring or looking at urethras. So I'm really sorry, but I'll be honest and say that is one for me to check out.
That's all good. Fiona was wondering, when we're talking about, I think she means when we're talking about climacturia, what sort of is the range of liquid leakage that men tend to be experiencing? It does sound like there's quite a difference in the continuum. Is there, how much?
So I actually asked all of my patients, and
Oh, we've lost you momentarily, Jo. You back?
100 men, and
oh no, sorry, Jo. 1 second. The robots have taken over again momentarily. I think you're coming back into view. Unfortunately, I lost that whole question. It did seem like a full alien invasion just occurred. Let's hope not.
I didn't say very much.
Okay, so that was your practice run. Now for the real thing.
So in my own study, I looked at 100 men, and I got 50 men to do what we call usual care and 50 men to do this high intensity program. And what I found was that in both groups, about 36% and 39% experienced climacturia or arousal leakage at some stage. It tended to get better over time, and I followed some guys for 18 months, most for 12 months. Most men, like 88% of men in both groups, had 5 mils or less of urine loss. Only 2 guys in each group had more than that. One guy had about 50 mils, which was the most I've ever come across, and another guy about 10. But over time, all of those improved.
Okay. And was that the improvement that you noticed? You mentioned before something about a fast twitching pelvic floor. Is it an exercise that you're alluding to? I'm wondering what the group that did your protocol, what were they given that was different to usual care, if you could let us know that.
So 30% of everyone's pelvic floor muscles are made of fast twitch fibers. So physiologically, they're required for closing the urethra when we do certain actions like coughing, sneezing, going from sitting to stand, the typical triggers that both men and women have with this, what we call stress urinary incontinence situation. So typically those 30% fibers have not been trained in pelvic floor muscle training as far as the evidence goes. But because this was the clinical presentation of most of my patients, I actually thought, what's wrong with trying to train the 30% that we're not currently training? 70% are endurance or slow twitch muscle fibers that you need for holding onto your bladder content, that you need for holding erectile blood flow to maintain, tumescence. So we really needed to train both the fast and slow twitch fibers to get the whole pelvic floor muscle functioning correctly. And this was just missed in previous studies. There's been such variation that even today there's no clear recommendation for a program that works because there's just been too many variables. Even the measure of continence or incontinence, some people say 150 grams of pad weight per 24 hours is acceptable. Some people say 1 pad is acceptable. I say no pads and no leakage is acceptable. So we really needed to lift our game on our measures and objectifying what is satisfactory.
Yeah, understood. So when you mentioned there's no exact protocol with training the fast twitch muscles, is there? I'm just wondering, there's an action that people listening could take away if they're already doing pelvic floor exercises. Is there anything? It sounds like them doing them when they're actually in motion as well as being stationary is a good idea. Anything else they could do?
Yeah, so a typical one that we refer to that has been proven in women is called the knack. So what they do is they engage their pelvic floor, so they quickly think of holding on the front passage, the urinary sphincter, and then drawing that up. So for a guy, it's a squeeze and lift. I always say lift your nuts to your guts before you stand up. And then take 2 or 3 steps, still controlling that contraction, and then gradually release it. And that fast twitch response initially will stop that leakage going in that 1 or 2 seconds it takes to transfer from sitting to standing. If you cough or sneeze and you know that's a trigger for you, you can do the same thing. You can very quickly draw up that pelvic floor, closing off that urethral sphincter to limit or eliminate the chance it might run down or empty and leak into a pad. So my goal was try and get those fast twitch muscles, try and do 10 as fast as you can and time it. So I was using a little stopwatch and looking at it on the ultrasound, and I found that if there was 10 contractions performed in less than 10 seconds, with a goal being around 8 seconds, that most men no longer had this stress urinary leakage occurring. So 10 rapid ones, as quick as you can, 5 or 6 times through the day will really help stress incontinence. Performed in standing is better because you've got some load of your upper body weight. So that's a simple approach.
That's wonderful. Thanks for that little like practical chunk. Now, is that when you say 10, is that the 10 nuts to guts? I'm going to definitely remember that, by the way. That is the perfect perfect language, I think, to get that in our heads.
What happens, and it's I really did research, so the word nuts is very translatable across many cultures, and every single guy I've ever spoken to, it smiles and has a bit of a chuckle, and I can see his eyeballs almost roll around as he practices it as I say it, and he's immediately aware of it. Plus he can go home and stand in front of a mirror and check that he's moving that area of his body more specifically and avoiding using his abdominal or gluteal muscles. So it's something they can see their testes rise, their penis retracts slightly, and they get that whole visual feedback that they get with the ultrasound scanner as well. So yeah, it's a simple thing and it makes everyone feel a little bit more comfortable. There's a little bit of humor in it, and it's just nice to break the ice a little bit by not having such medicalized language.
Yeah, we've got a couple of people commenting on the nuts up approach. Someone's saying that's a new one, so that's always good. Got a new one to take away. And someone's outright said, lift your nuts to your guts. That's a great one. Sounding more and more like a greeting card as you say it. Lift your nuts to your guts. We've got a couple of great questions that have come through. Someone's wondering, would a penile implant have any effect upon urinary continence or climacturia?
Okay, so is the question, we probably need a bit of clarification. The likelihood of needing a penile implant for climacturia is usually something that would fix both problems, the erectile function and the climacturia. So I'm just curious, is this person asking the question, they've had climacturia since the penile implant? Because normally it's a treatment for.
That is a good question to ask back. If whoever asked that question, if you can confirm whether this is because you have a penile implant and are experiencing urinary incontinence, or this is related to would having a penile implant have an impact. I will move on. So we've got a few minutes left. Someone's asking, could about 6 months out from their operation, is there any way of doing sort of self-test progress other than visiting a physio and having an ultrasound? And they have said their physio is absolutely wonderful, but they'd like some way of getting personal feedback as well.
Okay, so a really lovely patient by the name of Chris Robinson from Sydney, he developed a whole process of measuring himself. Anyone can access it. It's an online resource. It's called urilog.com. And
is that URILOCK.com?
log, Uri, URILOG.
Okay.
.com. I think it's .com just on its own. And what you can do is you can go in and plug in all your own dates and information. You can even start weighing your own pads so you can get a bit of an idea of your progress. And the way Chris has designed the package is that it automatically graphs your progress. There is a one-off $10 fee to actually access that, but he really wanted to try and get other men having similar experiences to him to have something that they could work with to better do things from home. Even you can even enlist your physiotherapist or urologist onto the system as a health professional, so they can also look at your results and whip out graphs and things like that, so you can test that. But yeah, personally, it's just a good idea, I think, just to go and have a look in the mirror and make sure that you're not overdoing the abdominal component and that there's very little movement. It needs to be quite subtle and definitely no noise. There's sometimes men feel like they really have to strain and grunt to do this action, but it's much more subtle than that.
That's brilliant, Jo, and I'll make sure that online resource, put that in the follow-up email, which should be out tomorrow.
Okay.
No, it was great. We've actually wonderfully had a message through from somebody who has a penile implant themselves, quite a recent procedure for them. They were saying that, I've actually mentioned another thing now, that they found that the implant has generally reduced incontinence.
Good.
And yes, in this case, he was 3 years post radical prostatectomy and he had Peyronie's and was still experiencing leakage at that point. So it does sound like the implant has improved things.
Yeah, and that's a really good story because he's waited 2 to 3 years. He's been through the process with his urology, guiding what was necessary, and developing Peyronie's after all of those other experiences is, quite a distressing thing. So he sounds like he was really appropriately managed and a really good result for him.
Yeah, absolutely. Well, look, thank you so much, Jo. We've got a minute left. If anybody has any final comments or questions they'd love to ask Jo, please pop them in the chat box now. Jo, I think personally, the last thing I want to ask is, look, I want to know more about why does pelvic floor also have an impact on orgasm and erection? I think the more that I learn and hear about the pelvic floor, the more I think, look, it's actually this magical wonder muscle that we all should be working more to get all of these benefits. But it does sound like in a few moments you've mentioned it definitely impacts erection. I'm just wondering why is that?
So there was some breakthrough research in 2005 by a UK physiotherapist by the name of Professor Grace Story, and she was able to show that if men did pelvic floor exercises just 3 times a day and they had erectile dysfunction, that in 75% of the cases they actually improved, with 43%, I think, curing of that condition. So that got me thinking, perhaps we could translate this into men following radical prostatectomy. In the time I started my research, that was my goal. Then a couple of others did do research on, and they were actually able to show that the combination of pelvic floor contraction and time helped the erectile function improve, because it's like having your own vascular pump on the inside. It's bringing in freshly oxygenated blood flow to help that neuropraxic, that nerve, cavernosal nerve recovery. And it's been shown that it certainly helps after about 12 months. What I wanted to show was if we could do that sooner, within 3 months of my study, I would be very pleased. I wasn't able to show that in that short time frame because it takes 3 or 4 months at least for the nerve to recover. But after that, from 6 months on, there was definitely much, much better erectile function occurring. So there's 2 muscles, ischiocavernosus and bulbocavernosus, that are very involved in that are part of the pelvic floor that we're activating, that help erectile function improve.
Great. Well, then it sounds like maybe some final advice as well. Is anybody listening, look, even if you feel like your incontinence journey is behind you, to keep going with the pelvic floor muscle regime that you clearly got down pat, because it has an impact on everything else that you're working on as well. And I love that, really, the visual of, look, if you're using a vacuum pump on the outside, it sounds like, hey, you've got one on the inside as well, and you can activate it at any time. So nuts to nuts, everybody. We've got some lovely comments just coming through. Finished. Everybody's just congratulating you, Jo, on completing your PhD. I agree. It's a huge achievement. Well done.
I am pleased to let you know that the actual paper that I've written has basically been approved for publication. So this will be public knowledge soon with all the exact numbers and all the final data. So it was 6 years of hard work, but it's all to try and help improve the everyday quality of guys and their partners, because it impacts everyone.
Absolutely. Thank you so much, Jo. I really just admire your work, and thank you so much for putting that time and effort so that everybody can benefit. And once it's published as well, like, I'm going to be definitely reading it, and I'm sure we'll do even more follow-up work together, telling people even more, insights that you got from that experience. Thank you. And I know that a last comment we both want to make is that Men's Health Week is on next week. That's another online resource that I'll be sending through with the follow-up video tomorrow morning. Men's Health Week events will be going on across Australia, and the website itself, you just look at your location, it'll tell you what's going on. Jo, is there anything in particular that you'd like to plug for the week?
Yes, well, the Physiotherapy Association has asked me to do a little bit of work with them, and we're going to be doing a little bit of coverage of how heart health and heart health are related. So if you've got any concerns with your erectile function, it could be an indicator of some cardiovascular issues. So it's now recognised as a really important health indicator for whole body health. So there's a window of about 3 years. If you notice any changes in potency, it may be linking to a cardiac risk. So don't be afraid to go and get some advice, maybe some investigations to address your whole health.
That's wonderful. So there you go. 2 main key takeaways tonight were nuts to guts and hard health. I'm very, very much approve of this webinar. It's been pun-filled to the max. So thank you so much, Jo. Thank you,
everybody. So much to everyone. I know there's been a lot of people, over 200 that are joining in tonight. So it's wonderful work that Victoria's doing, and I'm just really privileged to share this space with you. So thanks to Victoria.
Oh, Jo, that's lovely. Thank you. And thank you, everybody, for joining us tonight. And we'll be sharing the video tomorrow morning, so check your inbox then. Goodbye.
Bye. Can I do this?
Oh, I missed you.